All right, great. Can everyone hear me in there?
Yes.
Okay, thanks for hanging in there. Last session of the day before we head off to cocktails and dinner. Echo Rod's comments, learn as much as you can, be a sponge, ask all the questions you can of your faculty, and enjoy this career that you're embarking on. I do want to thank Rachel and Judd and Medtronic for sponsoring this demo, and all of you will get a chance to work with the Medtronic Mazor robot tomorrow and play some screws, but I'm just going to give a quick demo. Briefly before that, I just want to take that panned out shot to show the equipment that's involved. So the workstation is here in the back. The Mazor workstation, there's a 12-foot cable, so it doesn't have to be parked right here by the operating room table. It has HDMI output, so you can go to every monitor in your operating room or the one on the ceiling, so everyone can see what you're doing. In addition to that, the robotic arm is actually attached to the table, so it's table-mounted robotic arm. This entire assembly is stored in this workstation, so from the standpoint of the OR personnel, it's very easy to move it in and out of the room and storage. So this arm gets attached to the operating room table. It's then affixed to the patient. And because that's the case, we only need one point of fixation. It's usually just a PSIS pin that looks like a Caspar pin you might use for an ACDF. There's an attachment from the patient PSIS pin to the robotic arm. There's an end effector through which all the instruments go. And then there's the reference array. And since this is table mounted and patient mounted, there's really only one reference array. It's very difficult to inadvertently bump the reference array. You can ultimately get a shift of the shoulder or a shift of the patient. We have to be aware of that. So during the technique, we're very, very careful about placing our instruments down. I never like to see anyone gripping the instruments with their fist. I'm a neurosurgeon, so we like to teetotal our instruments, so it's 2 or 3 finger technique. And then the optical array camera is usually at the head of the bed over anesthesia. Generally, we set that up at the beginning so we see the reference array and all the instruments, and so we usually don't have any line of sight issues. I'm going to go back to the back, though, and I want you to switch over and look at the software, because that's really where the money meets the road. Here's a software for CT to fluoro. So this patient already had a preoperative CT scan. Judd has been kind enough to already plan screws from L3 down to S2. He's also planned some decortication sites for a facet fusion and decortication sites for bone resection, so facetectomy and laminectomy. And I'm going to show you how easy it is for planning. So I'm going to add screws at L2. So I'm going to go to the L2 level. I'm going to add a screw. It's going to give me the same pair of screws that were last placed in diameter, trajectory, and length. And all I'm going to do with my mouse is just make some fine adjustments of these pedicle screws. And again, I can individualize each pedicle screw for the angle and the facet. I can make these screws larger, but either by diameter here on the left or in length. And very quickly make adjustments to add screws. I can look at the simulation on the AP view or in the lateral view, and I can start to imagine how I'm going to place the percutaneous rod or a mini open technique for the rod placement. And then I can actually plan inner bodies. I can go down to L5 and plan an inner body for L4-5 by adding this. Here's a simulated cage. I can take this cage and I can rotate it. I can place it as if you would do a T-lift technique for a right-sided approach. Here on the sagittal, you can see the simulation of the segmental anatomy. I can add height to the implant. I can add length to the implant. And then I can ultimately simulate what the correction will be at that segment simply by hitting this button on the left. So again, from even a 1-level or a 2-level degenerative spondy, we can start to take those principles of spinopelvic parameter and sagittal balance improvement and take that to the degen cases. The nice part then, as I mentioned earlier today in my talk, is the decortication. So we're going to go up here to L1, L2, and we're going to plan some decortication pathways. We're going to add this decortication tool over to the left side. And I'm going to plan to decorticate that facet joint at L4-5. I can make an adjustment as to the length of that decortication site It's a 7.5 millimeter decortication tool, and then I can backfill that with bone graft. I can quickly add another decortication site for the opposite side. And again, this is especially helpful for MIS cases, but it can be done for open cases and MIS cases. I can even plan my incision. I can go down here, change the windowing, see the soft tissue envelope, and I can plan my incision for an MIS technique from the midline, and I can estimate my incision to be 4.5 centimeters off the midline on that side, only 4 centimeters on that side. So I can customize, for instance, a trauma case where I'm gonna stabilize and fixate and fuse with just percutaneous incisions. So with that, again, this robust software planning, this can be done ahead of time if you do a CT to fluoro workflow, or if you prefer the scan and plan, you can use the O-arm to do the spin with the patient in the prone position, and then do the planning on the workstation, then execute placing the screws and the instrumentation. So now we're gonna go over to the cadaver and sort of demonstrate one pedicle screw placement and one decortication. All right, so it wasn't mentioned earlier, but there are a few steps to get the registration of the robot. So prior to this, Rachel and Judd have taken a couple of fluoro shots, registered the Mazor robot to the preoperative CT scan, and registered the navigation. So this is a dual navigation system and robotic system. And because it was a robotic system first and the navigation was integrated, if the navigation for some reason is completely off, the robot is still accurate to 1 millimeter accuracy. So we have the head up here and the feet down here. The arm is mounted on the patient's left side. In this case, in the lab, typically it's mounted on the right side in the operating room in a very, very efficient manner. So Judd's gonna send the robot over to the left L5 pedicle screw. There is a monitor here that can be draped within the Mazor drape so that I could operate it myself. But as a surgeon, I'd rather focus my attention down here rather than on the computer screen. So we'll go ahead and send it, Judd, to the left L5 pedicle. A lot of safety features built into this, so when it's moving, there's a green light that's blinking, and there's a buzzing sound, so you shouldn't touch it. When it stops, you hear a bonk. So now we're at the L5 pedicle screw. I can ask Judd to raise or lower the arm if we need to. It looks perfect. I'm also gonna take a machete, go right down the pipe and make a little stab incision. And again, we're just demonstrating kind of the least invasive technique. We're gonna extend that incision just a bit all the way down to the bone. And then it's really 4 steps or 4 sets of instruments. The first is a navigated cannula. The next is a navigated Midas drill. The next is a navigated tap, and finally a navigated screwdriver. So this is the first one. It's a navigated dilator with a soft tissue cannula. We're simply gonna go down, and with just a couple of finger twisting technique, we're gonna be set on bone. Now I need to see the monitor. And then we're gonna slide our cannula down. We can see the navigated instrument in blue, the screw trajectory in green, and the yellow is the planned screw. I'm gonna leave that cannula and take the navigated dilator out, go to my Midas for Mazor, which is a 30 millimeter drill bit. And we're just gonna go down with power and try to prevent my carpal tunnel from getting worse. We're gonna lift the drill off of the bone. Give me some power. And then we're just gonna drill a pilot hole. And again, on the navigation, you can tell it's a very rigid system. Take that out. And then we're gonna go with an under tap navigation, again with power. We can see the navigated tap there in blue, the navigation confirmation with the green, and then the screw trajectory. And then we're just gonna fire this down. We'll back that out. The accuracy is so good. I know we're all trained to start sticking ball probes in there and feel the channel and all that. Really don't need to do that. We're gonna take the cannula out, switch over to a navigated powered screwdriver. Again, we're going to confirm the trajectory, the virtual screw, and the plan screw. And then again with power, with very little 2 to 3 finger technique on the hand drill, drop that screw in about 10 seconds. We're going to release the screw, and this is an MIS screw, so we'll just release this here, gentle tug, and that's one pedicle screw. So we've standardized the placement of a pedicle screw using the navigated robot, 4 steps, really no reason to do ball probes down the pedicle shaft, really no reason to do neuromonitoring. Again, the navigation of the robot is 1 millimeter or less accurate. So then we're gonna demonstrate just the decortication. So let's actually go over to right L4-5, and we'll do the decortication at right L4-5. Again, we're gonna now do a fusion part of the operation using the robot, which we were not able to do until last year with the most recent software and hardware upgrade. We'll again make an incision down through the skin and down to the fascia. Usually enlarge that just a little bit. And again, while we're showing the least invasive technique MIS, you can do this open or mini open, navigated dilator and cannula. Very, very soft technique by pushing the instrument down. You can see the facet joint. We're gonna drop the cannula to keep the soft tissue out of the way. Take the navigated cannula out. We've now switched the drill over to this acorn bit, which is 7.5 millimeters in diameter. Those decortication trajectories and plans are up to 20 millimeters deep. And I can simply go down the cannula, verify on the navigation. There we go. And then using the same technique, kind of a bird beaking type of technique, we're actually gonna drill down. And actually this trajectory was for part of the bone resection. There's another trajectory for the facet fusion. My apologies. But again, you see the idea, we're creating a 7.5 millimeter by 20 millimeter hole. This drill bit is designed to pull the autograft out, which you can use if you want for the autograft. We don't have the equipment today, but there's essentially that caulk gun that I showed in my video. It's preloaded with up to 2 cc's of DBM or whatever autograft. You slide that down the cannula, squeeze the pistol grip about 4 times, and you've delivered 2 cc's of autograft into that facet fusion. And so now you can imagine if we can do a decortication and facet fusion using the robotic arm with that precision and that accuracy, we can then use the robot and the computer planning and the decortication tool to do our actual primary decompression. So Judd has moved it to another trajectory. And so we'll just repeat the exact same 4 steps. So small incision through the skin and fascia, all the way down to the bone. Navigated dilator and cannula. Confirm that. And maybe we can zoom in on the other screen. Perfect. So that's now the facet decortication. I can take that same acorn drill bit, go down the cannula, and then again do the facet decortication. You can see the tip of that acorn bit is pretty sharp, but it doesn't cut on the tip. And so what we've been able to do now for the past 6 months is use this tool to actually do our primary decompression. So for the first few cases, I would plan and leave 1 millimeter of bone and facet joint or facet bone before I got to the ligament flavum, but most of us are doing the surgery because there's very thick ligament flavum. So after a few cases of proving the accuracy and precision, I put in the microscope and my tubular retractor and see that there's a little eggshell of bone. Now what I do is I plan down to the ligament through the entire inner surface of that facet joint. And so now we're able to, for instance, if we can go back to the other monitor, Judd's gonna show you a level where we've planned 4 or 5 trajectories using that decortication tool, and you can imagine with 3 up to 6 or 7 trajectories, we can actually do greater than 90% of the bone resection for a TLIF, hemilaminectomy, and even contralateral decompression using the robot and taking advantage of the computerized planning and the precision of the robotic arm. So you can see several overlapping trajectories of that decortication tool. And if you just plan those decortication pathways and trajectories appropriately, you've essentially completely done the decompression. So very much look forward to tomorrow when you all will get to rotate here to this station, and we'll let you drop some screws. Be happy to answer any questions, but the Mazor robot for me has been just an amazing advancement in my toolbox and has been able to allow me to do 70 to 80% of my lumbar fusions, degen patients as an outpatient, especially with this type of technique, and now more standardized and more efficient because I can use the tools to do the decompression, and now I can just put in my microscope and finish off the decompression with about 5 to 10 minutes of removing the ligament, residual facet joint, and now I'm back to doing the interbody part of the operation. And with that, hopefully we'll give everyone back some time so we can get to happy hour. Any questions?
Thanks very much, Dr. Chua. That was great. Any questions for Dr. Chua? I think some exciting times with the ability to use the robot to remove bone. You know, it's definitely a step in an interesting direction. So, Dr. Chua, when you decorticate those facet joints, what are you doing to salvage that bone?
So with a decortication tool, that drill bit's actually designed, and it actually pulls out a little bit of, I think Rachel already wiped it off, but the drill bit actually pulls some of that bone out. That's number one. Here's a little bit of a smear of bone that came out with that decortication pass. You know, much of that bone, though, is kind of cartilage, and I'm not sure how good that bone is. It's kind of toothpaste consistency, so I typically don't rely on that autograft. I oftentimes do a little MIS technique into the PSIS, and there's a device that I can get 10 cc's of cancellous bone out of the iliac crest, and I'll use that. I'll use some of the other DBMs that are produced and designed specifically to go into the gun that's delivered into this spot. And then in some cases, I'll use a BMP in an off-label use and get an extra small sponge and just cut it into pieces and stuff it into that facet joint.
Nice. Cool. All right.
I just have,
oh, yeah, Rod has an
I have one
announcement.
more question, Rich. That was great. What's your thought on, so I don't know, I think you talked about it earlier, but what's your thought on, how much of this technology, like you talked about decompressions, doing osteotomies, do you think in like 3 years we can just let the robot just do the whole case?
I do. I actually do.
Yeah.
And my hope is that before I retire, I get to be like the Da Vinci surgeons and sit in the corner with my shoes off and get to do the operation. But realistically, I think the engineers are very close to figuring out how to make this a mobile arm rather than a static arm. Right now, we're using a static arm and just doing reproducible drilling and bone resection. It's just a matter of time before the robotic technology will be to the point where it's a fluid moving arm, just like the robots are building the Tesla. And again, if you look at any video of a Tesla, 90% of that car is made with robots. There's not 10% is with a human touching it. So I do think we're moving in that direction, but it's, you know, step-by-step iterations of the technology. But I do think, I don't know if it's 3 years, it might be 5 years, but I do think that we're going to be able to do that. Some of you may know we're already doing remote technology surgery across 5G. So there are surgeons in the United States doing surgery remotely using 5G technology in Europe and in China. I think very recently was the first case where they did a spinal fusion remotely using a robot in China, where the surgeon was in the US doing the manipulation of the robot, sending that information across 5G to China, and the robot there is doing all the movement. So the technology is out there. Just think about the technology in your iPhone that's in your pocket right now. That technology building a Tesla, the automation of electric vehicles and hybrid vehicles, you put that into these machines, and I think sky's the limit in a short period of time.
And then one less technological question is, I'm still trying to figure out, what do you think is the best incision for one level? Because I don't know, I'm kind of going back to doing one midline.
Well,
instead of 5 stab incisions. And
it's a great question.
So,
I will tell you, having taught hundreds of surgeons the robotic technique, the surgeons that struggle the most with the robot are the ones who try to do a small midline incision for, let's say, an L4-5 TLIF with instrumentation. The beauty of this software is to optimize your trajectories of the pedicle screws. In order to do that, it's more of a lateral to medial trajectory than we're all used to doing with our open technique. So I think if you can get comfortable doing, now perhaps you could do a midline incision to do your decompression and inner body, but then do a couple of stab incisions. And I know it doesn't look great, but they all heal just fine. Or you can go to doing 2 paraspinal Wiltse type incisions, 3, 4, 5 centimeters off the midline, put in your screws through those incisions, through the fascia, do your decompression however you want to do it, endoscopic, microscopic, tubular, mini open, or pedicle screw-based retractors. You have all of those options when you use the robot.
So what do you do? Because I like the midline, bigger incision, keep the fascia intact, and do Wiltse through the fascia.
For the screws, then what do you do for the decompression and inner body? Do you go back to the midline and strip it off?
Just do it through the stab incisions.
Yeah, that's essentially, I essentially do 2 paramedian incisions. I use the robot and put in the opposite screws first, and then I'll drill and tap my screws on the ipsilateral side. I'll use the robot to do my facet fusion on the contralateral side. I'll use the robot to do my facetectomy and laminectomy on my side. Then I put my tube in, then I bring my microscope in, finish off the decompression, do the inner body, and then the robot goes out of the way, the microscope gets out of the way, drop the 2 screws that I've already pre-drilled and pre-tapped on my side, drop the rods and close. Prior to using the robot, I would do the standard navigation technique of a spin, do your surgery, do another spin, make sure all your screws are good. This is so accurate and so precise because of the planning and because of the registration. I no longer do a spin. I do 1 AP and 1 lateral, make sure my screws are good, close and be done. And this has made me a much more efficient surgeon. I thought I was pretty efficient and pretty fast, but the robotic technique and standardization, and you just saw 4 steps, and I can even get it down to 2 steps. I can skip that dilator and I can go right to my Midas drill and cannula, drill my hole. I can skip my tap because I've planned the screw to go in a nice flat spot, and I can drop my screw. So I can even make that technique even more efficient with 2 steps to drop 1 pedicle screw.
Cool, thank you so much.
Nice.
Can I?
Great. Oh
Yeah,
yeah,
go
we have
ahead.
another question.
I would like to ask, does it have the same accuracy for levels that is away from the navigation frame? Like, for example, if you are doing long construct.
Yeah, I think the question is the accuracy of the navigation as good the further away we get from the frame? Was that what the question was?
Yeah, that's my question.
Yeah, so it is as accurate, and I would argue it's more accurate because this is such a rigid arm attached to the table and to the patient. So there's less play in this than there is, let's say, your O-arm stealth navigation system. And so it is as accurate up at the upper middle thoracic spine as it is down at L5S1 or the F2AI screws that we showed so elegantly earlier today. And by the way, this is, this bridge that attaches the robotic arm to the patient with a PSIS pin, although that's not on label, we use this attachment. We go all the way up, we can go all the way up to T7. and it's accurate, and the reach is there. And so we can minimize the amount of times we may have to do registrations. When we do long constructs like that, some people have the idea that, gosh, we need to take the robot and disconnect it from the patient and move it up and register again and move it up and register again, and that's simply not the case. We may have to use our C-arm to re-register because you can only get 3-4 levels at a time, but the robot will reach all the way up to the mid or even part of the upper thoracic spine simply with an attachment rigidly into the PSIS. There are other attachments of the robot to the patient, so if it's an open case, just like your navigation with O-arm and stealth, there's spinous process clamps, there's dual spinous process clamps, but for my preference in a lumbar degen practice, it's almost always this PSIS pin.
Awesome. Well, thank you so much. This concludes the day, and I guess the next event is the happy hour.
Yeah, so you guys, so you can